Assalamu alaikum.
Waalaikumsalam.
How are you?
We're good.
Alhamdulillah. Good afternoon. Hoping, are you available now? How many candidates available?
There should be just one more person.
One more only? Okay. So good, let us start by Al-Kitab before we are starting this phase, inshallah. Okay, Faiz.
Yes, doctor.
You can start.
Oh, I'm not presenting today.
Doctor, can we start now?
Yes, yes. Go ahead.
Okay. Okay, Assalamualaikum warahmatullahi wabarakatuh. So today we will be having a dermatology seminar that will be supervised by Dr. Mossad. So this is the topic that we will be present today, where we will start with the hemangioma, atopic dermatitis or eczema, scabies, and lastly the Stevens-Johnson syndrome. So let me start with the hemangioma that will present by me, Nur Ilham Sarah binti Tahri. And this is the flow of my presentation, where I will start with the introduction and lastly briefly about the management. For the introduction, let me see the definition of the hemangioma. So hemangioma is come from the Greek word that means hema means blood, angio means vessel, and oma means tumor. So hemangioma means a tumor of the blood vessel. And it is a benign vascular tumor that arises from the proliferation of the vascular endothelium, and it characterized by two phases that are growth phase and also the involutional phase or regression. And this benign tumor is rarely transformed to malignant, and the lesion may present at birth or it become more apparent after first or second weeks of life. And the lesion may be localized, may be more extensive, and it also can rise internally at the organ, for example, liver. For the epidemiology, the prevalence, the hemangioma happen 1 to 10% worldwide, 5% in the newborn, and 5 to 10% in the 1-year-old infant. For the onset, 55% of the hemangioma present at birth, and at the rest is developed after first or 2 weeks of life. And this hemangioma is most common in the female, where the ratio of female to male is 3:1. It's also common in the premature infant, multiple gestation, and also low birth weight infant. So for the pathogenesis, the causes of the hemangioma is unknown. However, based on my reading, most of them suggest that hypoxia may be the cause of the hemangioma. So hypoxia means the inadequate level of oxygen in the tissue and cells. So when there is inadequate level of the oxygen, our body will try to send more oxygen to the hypoxic cell. By it will stimulate the hypoxia inducible factor 1 alpha, for example, vascular endothelial growth factor group 1 and also insulin-like growth factor 2. So this factor will help in the vasculogenesis and angiogenesis. So vasculogenesis and angiogenesis will help our body to send more oxygen to the hypoxic tissue. And this mechanism may become more extensive that lead to the hemangioma. After that, This hemangioma will be having involutional phase where the site of the hemangioma may be replaced by the adipose tissue. This is the explanation from the picture. So for the clinical course, I will touch about the clinical course of the growth phase and also the involutional phase. As you can see in the graph, the growth phase of the hemangioma is really rapid at the first 4 months of life, and after that it becomes slow phase. It becomes slow, and it also can be static. And after a few years, the hemangioma will be having slow involutional phase. For the involutional phase is different based on the different individual. So some of the patient may have the involutional phase at the age of 50 years old, 70% at the 7 years old, and most of the 90% at the 9 years old. And after the involutional phase, 20 to 40% will leave the residual changes in the skin, for example, scarring. For the clinical manifestation, I put the clinical manifestation based on the clinical subtype of the hemangioma, where there are too many classification of the hemangioma based on the different journal. However, this is I take from the pediatric protocol. So based on the pediatric protocol, the hemangioma can be classified into the superficial hemangioma, where it indicates 50 to 60% of the cases, deep hemangioma 15%, mixed hemangioma 25 to 35%, and multiple neonatal hemangiomatosis 15 to 30% of the cases. So let me look by one. For the superficial hemangioma, is also known as the strawberry or papillary hemangioma. And as you can see in the picture, the lesion is bright red and it can be protuberant. And the lesion can be compressible. However, you cannot compress it too much that it can lead to the ulceration. And the lesion is sharply demarcated. And this superficial hemangioma can reach its maximum size by 6 to 8 months. And it also have the risk of further residual fibrofatty tissue after the involutional phase. For the deep hemangioma, as you can see in the picture, the hemangioma is more diffuse and the margin is less defined than the superficial. And the lesion can be firm or compressible, and it is warm masses as it filled with the blood vessel. And the overlying skin of the hemangioma may appear normal in color, or it may become bluish. And this hemangioma can grow up to 12 to 14 months. Next, we move to the mixed hemangioma, where this mixed hemangioma have both superficial and deep characteristic of the hemangioma. As you can see in the picture, the hemangioma is bright red, and it also have bluish discoloration on the skin. Next is the multiple neonatal hemangiomatosis, where the lesion of the hemangioma is numerous, multifocal, and widely distributed. And this lesion size is range from the few millimeters up to 1 to 2 centimeters, and it can be happen through out of the body. And this lesion may just happen on the skin, or it can also happen in the visceral organ, for example, liver. Also, this is the illustration of the superficial and deep hemangioma, where as you see in the superficial hemangioma, the hemangioma is protrude the skin that lead to the bright red color. And for the deep hemangioma is do not protrude the skin and just remain under the skin, that may give to the bluish discoloration. So generally, the hemangioma can present at the birth, or it can become more apparent after first 2 weeks of life. And the lesion may become erythematous if it is superficial, or it have blue marks if it's deep blue hemangioma, or the lesion can become paler initially, and subsequently it will develop a fine telangiectatic pattern that known as the spider vein before the growth phase. And the favorite site of the hemangioma is at the face, scalp, back, and also the anterior chest, where 50% of it can be located at the head and neck. For the pattern of the facial involvement, it can involve the frontotemporal region where you can see in the picture it is number 1. Also can involve the medullary region, number 2, mandibular region, number 3, and also the frontotemporal region, number 4. And the lesion may be solitary or multiple. And if there is more than one lesion, it has a risk of getting the visceral hemangioma. For the regression, the hemangioma may have the involutional phase, and this involutional phase may be anticipated when the lesion develops pale gray area centrally, and after the involution, residual skin may remain. There is 1% of the hemangioma can be life-threatening, and 10% can cause an impairment based on their location, which I will show after this. For the diagnosis of the hemangioma is mostly based on the clinical diagnosis, but we also can do some imaging tests in order to confirm it. The chest, you can do the MRI or ultrasound, so we can see how far the hemangioma go under the skin and whether it affect any internal organ. And this diagnosis should be done by the pediatric dermatologist. For the differential diagnosis, there are too many differential diagnoses for the hemangioma, as the lesion is about the same. However, we need to remember that hemangioma have growth phase and also the involutional phase, where most of the other differential diagnoses do not have the involutional phase. For the investigation, almost 95% of the diagnosis, as I said before, based on the history and physical examination. It is because of the typical appearing vascular tumor and also the history of lesion, where it characterized by the proliferation at the early infancy and also the involutional phase after that. However, we can do some other investigation in order to confirm it. For example, we can do the laboratory studies. We can use the marker of the hemangioma proliferation and differentiation. As I said before, the hypoxia inducible factor 1 alpha is the has a vital role in causing the hemangioma, so that we can use the factor in order to investigate hemangioma. For example, we can use the serum vascular endothelial growth factor or unitary beta fibroblast growth factor, or you can use the matrix metalloproteinase. And also we can do the platelet count in the Casabat-Merritt phenomenon. So Casabat-Merritt phenomenon is one of the complications of the hemangioma, which I will explain after this. For the biopsy and excision, we can do for the histopathological examination and also the routine immunohistochemical studies, where the GLUT1 is the immunohistochemical marker in the both proliferating and involuting hemangioma. For the imaging studies, we can do to confirm the diagnosis. Also, this is the histopathological finding for the proliferation, involution, and end of the involutional phase. You can read later. For the complication of the hemangioma, the ulceration is the most frequent complication of the hemangioma, and it happens from 5 to 21% of the incident. And because of the ulceration, it can lead to the significant pain at the site of the hemangioma. And the ulceration also can increase the risk of getting infection and hemorrhage that can be result of the scarring and also permanent disfigurement of the hemangioma. The hemangioma also can cause the tissue destruction and also severe disfigurement that can lead to the cosmetic defect in the patient. For the large segmental hemangioma, it can lead to the malformation of the underlying structure, for example, the blood vessel, heart, and nervous system, such as in the face and pelvis syndrome. For the Casabat Merritt phenomenon, as I said before, is the complication of the hemangioma, where it is a combination of the giant hemangioma, thrombocytopenia, and also the consumption coagulopathy, where this Casabat Merritt phenomenon have severe thrombocytopenia that result from the platelet trapping within the vascular tumor. So that's why during the laboratory studies, we can see the patient may have the thrombocytopenia if they have the Casabat Merritt phenomenon. And this condition is really life-threatening. So this is the face syndrome, where the word of the face is a mnemonic of the P, posterior fossa structural brain abnormality. H is the hemangioma on face, head, and neck. A is the arterial lesion. C is the cardiac anomalies, and I is the eye abnormality. So hemangioma can lead to this abnormality. Next is the pelvis syndrome. It's also the word of the pelvis also derived from the mnemonic P. P is the perineal hemangioma with any of the following, where E is the external genitalia malformation, L is the lipomyelomeniingocele, V is vesicorenal abnormality, I is the imperforate anus, and C is skin tag. And as you can see in the picture, this is the pelvis syndrome. Next, this is the picture of the Casabat Merritt phenomenon. For the other complication, is based on their special site. If the patient have the beard distribution of the hemangioma, the complication may the airway obstruction if it involves the upper airway and subglottic area. For the eye hemangioma, it can lead to the amblyopia, strabismus, and astigmatism. For the lumbar hemangioma, it can lead to the tetrachord, imperforate anus, renal anomalies, and also the sacral anomalies. For the management, most hemangioma do not require any treatment, and the active intervention is recommended in the most of the cases. However, we need to evaluate the hemangioma first before doing any management intervention. We need to look whether it is a no risk, low risk, or high risk of the hemangioma. So for the no risk or low risk hemangioma, it is hemangioma that is small, do not cause functional impairment, and unlikely to leave permanent disfigurement in the patient. So the management that we can do is just wait and watch policy, as the hemangioma can regress by the time. And also we need to educate the patient and parents. The parents should know that this is the benign tumor, and this lesion will be regressed by the time. For the high-risk hemangioma, it is hemangioma that is large, prognostically poor lesion, likely to leave permanent disfigurement, causing functional impairment, or involve extracutaneous structure. And it also a hemangioma that is large cutaneous or visceral hemangioma that can result in high output cardiac failure. So this hemangioma may require treatment. So when treatment is done, we need to do the treatment based on the individual customization, where we need to look for the size, location, presence of the complication, age, and rate of growth and involution of phase. And the risk of the treatment should be carefully weighed against the potential benefits. For the treatment, we can do the medical and surgical treatments. For the medical treatment, we can give propranolol for the patient. However, we need to monitor the side effect of the propranolol, as it can cause the hypotension, bradycardia, hypoglycemia, and others. Or we can give the systemic corticosteroid, and we need for this we need to watch for the growth retardation in the patient, hypertension, insulin resistance, and also the immunosuppression. Or we can give other systemic therapy, for example, the interferon alpha. However, this interferon alpha can cause the neurotoxicity. Or we can give the vincristine. For the surgical treatment, before the surgery, we need to evaluate the risk and benefit of the surgery itself. It is good to be done in the small pedunculated hemangioma, and it also can be done in the hemangioma that cause the functional repair. Most of the surgery that been done in the patient is usually to repair the residual cosmetic deformity, and we can use the laser surgery and surgical incision for the patient. So I think that's all for me. This is my references. Thank you.
So any questions for Ilya, or I will proceed with the next one?
That's good. Good presentation, Elia. Hi, Sarah. I will give the mark at the end of the session. Do you have any questions? The most important point with the skin is to be a good observer. Observation is very important, and to have the ability of differential diagnosis, it may be you need in this step to know the most common, and after that you will see more and more, so you can come to the bottom of the list. The other thing, always if you found anything in the skin, to ask yourself, is it solitary or can be connected to the system? This is a very important, because I hope, inshallah, at the end of this seminar, you know that the skin is the most important introduction to the body. Okay, because the skin also, as ectoderm, it is the same like nervous system. Many times you can find the combination between the skin and the nervous system, like cafe or spots, neurofibromatosis, like that. We are going to discuss, inshallah. Let's go for the second presentation.
And you can see my slide.
Yes.
Okay, so my name is Anis Amira, and I will proceed with the atopic dermatitis. This is my outline. So, atopic dermatitis, or AD, is a chronic pruritic relapsing inflammatory skin condition, and is the most common type of eczema, which is also called atopic eczema. And AD is also part of the atopic triad, which associated with allergic rhinitis and also asthma. So when a person have one of them, they are prone to have the others.
Is it common to write AD?
Yes?
It is common to write for this AD?
No.
Because autosomal dominant like that. So please try to decrease your abbreviation, okay?
Okay.
Only use the abbreviation which you already documented by the medical field.
Okay. So for atopic triad, nowadays, other allergies or include food allergy is also considered part of the atopic triad. So, so this one is atopic march. So what is atopic march? Is a natural history or the typical progression of the allergic diseases, which are the atopic triad I mentioned before, that often begin early in life. So usually, atopic dermatitis or eczema, which will precede the others first, which it present in the first years of, and then is followed by food allergy, rhinitis, and also asthma. So for the epidemiology of atopic dermatitis, for worldwide, the children is the prevalence of atopic dermatitis among children is 15 to 20%, while adult is 2 to 10%. While in Malaysia, according to the International Study of Asthma and also Allergies in Childhood, which is ISAC, the 12-month prevalence of AD has risen from 9.5% in ISAC 1 to 2.6% in ISAC 3, which has increased of 0.49% yearly. From what I found in NCBI, the overall prevalence of AD in atopic dermatitis in Malaysian children is about 13.9%. And the onset of this disease begins in the first year of life, and also 80% before 5 years old. And this atopic dermatitis affect all races the same. And its ratio among male to female ratio is 1 to 1.4 ratio, which is slightly higher in female. So for the etiology, atopic dermatitis is a multifactorial disease. So it's not caused by one etiology. So I provide 3 etiology here: genetic predisposition, which is filaggrin mutation that leads to skin barrier dysfunction, and also the triggering factors such as allergens, irritants, extreme temperatures, and also psychological stress. And the third one is immunological abnormalities, which type 1 hypersensitivity reaction. So I will go one by one. So in genetic predisposition, there is a filaggrin mutation. So a mutation at the FLG gene, which code for the filaggrin protein that contribute to the epidermal barrier function. So when there's a mutation of this filaggrin, it will lead to the epidermal barrier dysfunction. So when there's epidermal barrier dysfunction, the skin will be weakened. So the skin will become dry and also cracked. So it will be easier for the antigen to enter the skin. And this will lead to the production of the inflammatory cytokine, and because the inflammation process will occur. So this will lead to redness, swelling, and also itchiness of the skin. But however, in patients with atopic dermatitis, not all patients have this filaggrin mutation. From the study, 50% of the patients have this mutation. Okay. So the next one is triggering factors. I put only 3 examples. The first one is prolonged exposure to low humidity, which means that high temperature surrounding. This will cause dryness of the skin and also will lead to atopic dermatitis. And also the use of soaps that are neutral or alkaline that will change the natural pH of the skin. So, which the natural pH of the skin is about 5.5, which slightly acidic. And also psychological stress. This will also aggravate the skin permeability function. but it's not one of the factor that can cause atopic dermatitis. So when these factors combine, it will lead to atopic dermatitis. The next one is the immunological abnormalities, which is due to type 1 hypersensitivity. So this one will explain quite simplified. So upon first exposure to the allergen, the antigen presenting cells will process the antigen and present it to the T helper cell. So when this T helper cell will release the interleukins 4 and also interleukin 12, and this will activate the B cell. So B cell will proliferate and differentiate into the plasma B cell that secrete antibodies, which is IgE antibody. So this IgE will bind to the mast cell by the FC regions and will sensitize the mast cell. So and then after a subsequent exposure um to the allergen, so this will cross-link with the IgE on the mast cell and will lead to degranulation of the mast cell that will produce the histamine. So the histamine will lead to the reaction itching. Okay. So for clinical manifestation, the cardinal features for atopic dermatitis is the intense pruritus and also cutaneous reactivity. So we have 3 stages of this eczema. But you should remember that not all people will have this stage that as it varies from person to person. So in acute stage, the lesion is more to intensely pruritic with the erythematous papules. And for subacute is erythematous, flaky, and also scaly papules. For chronic stages, there are lichenification, which is the skin become thick and leathery, and also fibrotic papules. Okay, so for distribution of the rash, usually in infant, it affects the face and scalp. And the trunk also may be involved, but it's mainly face and scalp. For the older children, the rash occur at the skin flexures, which are at the cubital or popliteal fossa, and also at the frictional areas, which are at the neck, wrist, and also ankles. Okay. So for the diagnosis, for atopic dermatitis, according to PICS protocol, we use Hanifin and Rashkar criteria, which is the diagnosis is made on the basis of at least 3 major features, either pruritus, typical morphology or distribution, which I mentioned before. It's a facial and extensive involvement in infancy, and also fractional communication for the adolescents. Or chronically relapsing dermatitis, which is the definition of the atopic dermatitis itself, and also the personal or family history of atopy. And also minor features, reinforce the diagnosis of the atopic dermatitis, either xerosis, which is the abnormal dry skin or preauricular features, ichthyosis, or okay, or anything else under the minor criteria. So for differential diagnosis, there are a lot of differential diagnosis for atopic dermatitis, and I pick a few of them to explain. Okay, so seborrheic dermatitis is the most common differential diagnosis for atopic dermatitis. Seborrheic dermatitis, it will present as summer red greasy scaly lesion, and we often find that on the scalp and also the napkin area. So the way to differentiate seborrheic dermatitis from the atopic dermatitis is that in AD, atopic dermatitis, it usually spare the napkin. It's not involve the napkin area. Okay, the second one is the irritant contact dermatitis, which is acute to chronic eczematous lesion. This one has history of locally applied irritants. So to differentiate between this, we should ask for the risk factors such as the locally applied irritants. But this irritant contact dermatitis might coexist with the atopic dermatitis. So the next one is psoriasis. which often involve the diaper area and with well demarcated erythematous patches with little scale. And in contrast, and this in psoriasis, in contrast to the atopic dermatitis, is often involve the diaper area in infants, while in atopic dermatitis, it does not involve the diaper area. Okay, the last one is scabies, which is the involvement the involvement of the skin fold and in infants and the diaper area, and there is vesicle pustules on the palms and sole. So if there is vesicle pustules and also on the palms and sole, we should consider scabies rather than atopic dermatitis. Okay, so for the investigation, so atopic dermatitis is a clinical diagnosis. So laboratory test is not needed to diagnose atopic dermatitis. But when necessary, we can do blood tests, which we can see the elevated total plasma IgE level and also peripheral blood eosinophilia. And also we can use the skin prick test to identify the allergens. And we also can do the skin biopsy to exclude other skin diseases that mimic the atopic dermatitis. Okay. So for complication of the atopic dermatitis, is that the first one is it increase the susceptibility to secondary infection. The most common causes of the secondary infection is the Staphylococcus aureus, and also eczema herpeticum, which is the extensive cutaneous vesicular eruption, which caused by the herpes simplex virus. So this one is a rare complication which occur in less than 3% from what I've found on up to date. But if it's occur, it is a life-threatening condition, especially in the infant. Okay. So for the second one, the keratoconus, which is the conical deformity of the cornea, is occur due to the chronic rubbing of the eyes infection with the atopic dermatitis. Next one is cataracts. This is due to the extensive use of systemic and topical glucocorticoids, especially around. So it will cause cataract. And the fourth one is the atopic keratoconjunctivitis. This usually affect bilateral of the eyes or both of the eyes and can have disabling symptoms such as itching, discharge, and also tearing. Okay, for the management of the atopic dermatitis, how to manage atopic dermatitis? We manage it according to the severity of the disease. So how to know the severity? We do the physical assessment first. So if it's clear, so if there's clear skin, I mean that normal skin, no eczema, we use emollients. And mild, we use emollients and also mild potency corticosteroid. For moderate, we use emollient, moderate potency corticosteroid, wet wraps, and also tricolimus. For severe, we use emollients, moderate potency corticosteroid, wet wraps, tacrolimus, systemic therapy, and also phototherapy. We go one by one for the treatment. So the first one, is maintaining skin hydration. So skin hydration is the key component in the atopic dermatitis patient. So we need to maintain their skin hydration. So they can use emollient and also bathing with. So emollients are also we call moisturizers should be applied at least 2 times per day and immediately after bathing or hand washing. And bathing, we should use lukewarm water. Uh, and then after take bathing, we use the emollient. So this will relieve the symptoms of the atopic dermatitis. Aside from the maintain the skin hydration. Okay, the second one is controlling the pruritus. We have 5 of them. Okay, for the first one is non-pharmacologic intervention. Aside from the bathing and also the emollient, we can use the wet dressing, or we call them wet wraps, which can help soothe the skin. The second one, we can use the topical treatment, which either topical corticosteroid or topical immunomodulating drugs. So for the topical corticosteroid, this treatment should be carefully instructed by the physicians as as in order to avoid the side effects of the corticosteroid. Excessive use of topical corticosteroid may cause thinning of the hair and also systemic effect of the corticosteroid itself, such as weight gain, osteoporosis, and also growth retardation. And for topical immunomodulating drug, this okay. This which we need to use in child which more than 2 years old. Okay, tacrolimus oil or pimecrolimus cream may be used in the eczema, which we use the drug when the topical corticosteroid cannot be used in this kind of patient. But so why I put the in more than 2 years old? It shows that in studies that topical immunomodulating drug may increase the risk to have skin cancer. Okay, for next one is phototherapy. This phototherapy we can use narrowband ultraviolet B or ultraviolet A1 phototherapy. This generally reserved when the standard treatment which I mentioned before is not effective anymore. Okay, but this phototherapy also have adverse effect, which the short term and long term. So short term effect of the phototherapy include erythema, skin pain, pruritus, and also pigmentation. For the long term side effect, this also increase risk of cutaneous malignancy. Okay, for next one is oral antihistamine. This oral antihistamine is by blocking the histamine H1 receptors on the dermis. So histamine is one of the mediators that induce the pruritus. So we should use this oral antihistamine to control the pruritus. So next one is oral immunosuppressant. Okay, cyclosporin is used in the controlling pruritus also, and has been demonstrated to be useful in several trials. Okay. The next one is by avoiding the triggers and also the precipitants that can cause atopic dermatitis. So it's so to identify and eliminate the trigger-free factor that can cause the atopic dermatitis, such as avoiding the soaps and biological detergent, and avoid heat and low humidity that could cause the patient to be sweating, and manage the patient's stress and anxiety, and cut the patient's nails short so that they could not scratch their skin and more aggravated the atopic dermatitis, and manage the diet or avoid the food that could cause the food allergy, and also avoid allergens such as clean the bedding, always clean the bedding such as the pillow case, the mattress case. Okay. And then last but not least is the breastfeeding, how breastfeeding affect the atopic dermatitis. So so exclusive breastfeeding shows that have protective functions in the allergy diseases. So some studies show that breastfeeding reduce the risk for childhood atopic dermatitis, and this occurrence of the eczema was reduced by 46% in the patient that breastfed for at least 6 months. Okay, this is my reference. That's all from me.
Good. Is there any question to her or to me?
Can you clarify what is napkin area?
Yeah, the area of the perineal. They call it after the diaper. They call it diaper dermatitis or napkin dermatitis, which is very common if the baby has allergy and the family are using. That is an important point. Sometimes they are washing the clothes by a very strong washing solution, which can irritate the skin. In some area, they said if the color of the underwear are very good, the skin may be very bad. That's to say, especially in small infant, we used to ask them, please use a very simple detergent or even water, may be more safe. Okay, of course, it is the presentation for many cases like super added fungal infection like that.
Thank you.
Any other questions? Atopic dermatitis is an important point. And as your colleagues speak, it is a part of atopic triad, which also became very, very common. So please, if you find one patient of eczema, don't forget to clarify what about the history of other allergy, especially the rhinitis and the asthma. And the reverse. If he has asthma, and I asked you what the next system do you need to examine, you must tell I'm going to check the skin for sign of eczema. As eczema can be changed with age. Presentation in infant is different from children like that, okay? So it is very important. And to take care that some cases of like eczema herpeticum, which is a hypersimplex infected eczema, sometimes it can be life-threatening one because the viral can go very simply to the brain and cause encephalitis. So take care about secondary bacterial infection, please. Don't underestimate it because the skin barrier are very weak and easily to get staph infection, easily to get viral infection. Okay, good. Let's go for the third presentation.
Can you see the screen?
Yes.
Okay. So now I'll be presenting about scabies. Oh no. Oh no. Okay. This is the outline of my presentation. So scabies is also known in Malay as kudis buta, and it's an infestation caused by the female Sarcoptes scabii, which is an ectoparasite. It affects 5 to 10% of children worldwide, and it is usually transmitted through direct and prolonged skin-to-skin contact, and rarely it can be transmitted through fomites such as clothes or bedding. So what happens in scabies is that, okay. What happens in scabies is that they infest in the epidermis of the skin, and they burrow in the stratum corneum, which is the outermost layer of the epidermis. When they burrow in the skin, they deposit eggs. So then these eggs will hatch, releasing larvae. And these larvae, they go to the surface of the skin, and then they make their own burrows, which the burrows are shorter and called molting pouches. In these little pouches, the larvae then grow and mature. So after they've matured, a male Sarcoptes will then go into the burrow and mate with the female. So after the female is fertilized, it will leave a short molting pouch and go in the skin to burrow and lay more eggs, and so the cycle repeats. So other than eggs, they also leave fecal droplets, and the allergic reaction to these eggs and fecal droplets will cause the classic manifestation of scabies, which is itchiness. Okay, for the clinical manifestations, there are two main types of manifestations of scabies. One is called classic scabies, and the other one is called crusted scabies, which will be explained later. So in classic scabies, you would have pruritus, which is so intense, severe, and also worse at night.
You need to cover this picture better than that, please.
Sorry?
You need to cover the picture. We are not in need to see the private areas unless needed. Okay?
Oh. Okay. You can also have papules, which are small erythematous and excoriated. And you can have a lesion known as burrows, which are pathognomonic for classic scabies. So these manifestations, they manifest in typical areas where scabies can infest. So in this picture, if you can see, it usually affects the wrists, areas around the nipple, the axilla, the belt line, the genital regions, and in infants and young children, the distribution also frequently includes the palms, the soles, and the scalp. This is picture of erythematous papules, and this is scabies burrow, which is a wavy line. And this is pathognomonic for scabies. So if you see scabies burrow, then it's most likely scabies. Next, for crusted scabies, also known as Norwegian scabies, this may occur in immunocompromised patients or patients with cognitive deficiencies such as in Down syndrome. And in crusted scabies, you would see the skin is thickened or develop scales due to hyperkeratosis. And the skin comes crusted and can also have fissures like this picture in the bottom. The side of the fingers has developed fissures. The nails also can become thickened and dystrophic. For diagnosis of scabies, the diagnosis can be made upon consistent clinical findings. So if you have a patient with erythematous papules and scabies burrows at typical areas, such as at the webs of the fingers or at the axilla, then you can diagnose scabies. But sometimes the lesions are not always papular, and scabies burrows are often hard to see. And when the patient scratches on these rashes, the papules, they become excoriated or damaged. So it's often hard to identify the shape of the lesion. So you can confirm through microscopic detection, where you take a scraping of the skin and you check for scabies mites, eggs, or fecal pellets known as sibilla. For differential diagnosis, there are numerous conditions that can present with similar lesions to scabies, such as atopic dermatitis, contact dermatitis, lamellar dermatitis, arthropod bites, infantile acropustulosis, and Langerhans cell histiocytosis. Complications of scabies is usually secondary bacterial infection. So the patient may have impetigo, ecthyma, or paronychia, which is inflammation of the skin around the nails. Or there have also been cases of patient presenting with glomerulonephritis secondary to streptococcal infection. For management of patients with scabies, generally, you should treat all close contacts of the patient. And you should only allow the patient to go back to school 24 hours after the first treatment. You should wash close and bedding in hot water or by dry cleaning. And you should prescribe antihistamines for the severe pruritus and treat any superimposed bacterial skin infection. For treatment of scabies itself, the first line treatment is to give topical permethrin. So you would apply permethrin to all parts of the body and rinse off after 8 to 12 hours and repeat 1 week later. That's all from me. These are my references.
The role of health education in scabies.
What?
The role of health education, counseling the family.
Counseling the family?
Yes.
We should educate the parents about the condition and give them instructions on how to apply the treatment.
So suppose the father or mother in front of you, just inform us. You have 3 minutes to tell us.
Okay, so scabies is caused by a parasite which infests in the skin. It digs into the skin and causes itchiness in the child. And so you can treat this itchiness by applying a cream on your child's body. So you apply all over the body and leave it for 8 to 12 hours, and then you can rinse it off. And you should repeat this treatment 1 week later.
What do you mean by apply for all body?
Apply to all parts of the body.
Including the face?
Oh, not including the face.
How to prevent? How to prevent this disease?
Sorry, doctor, I can't hear you.
How can you prevent this disease?
You should avoid close and direct contact with other people.
Okay. So it is very important to understand our future job in medicine. You are not only a doctor who will write prescription, write medication, because if you are not giving the patient a full education and the full counseling, he may not get improved and they may infect others. And they may still coming to you. So it is very important. Number one, what it can come from. In contact with some patient, usually it is a family member, but adult can tolerate. So you must ask, is there anyone other one in the family have itching or not to see him, despite we may need to treat all the family if needed. The second part, how is the hygiene needed? Simple hygiene, we must wash the clothes. Even we must iron it to kill these mites. We need to trim the nails to prevent transmission, or even during itching, not injure himself and cause super added infection. So a lot of things must be done out how to apply the cream. All this is a part of our future responsibility. It is the same if you see one patient with asthma. If you didn't tell him enough knowledge how to prevent asthma, what is the thing he must avoid, the importance of adherence to the treatment, he will come to you every week with acute exacerbation of asthma, EPA. But if you are able to counseling him, you will prevent a lot of side effects. Okay, that's good. Any questions? A very important point your colleague didn't speak is if you found in the between finger, this area, if you found it is very, very pathognomonic. Okay, so during examining of the hand, don't forget to look for the web of between fingers. It is a very preferable part from the parasites. Let's go for the fourth one.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Today I will present the topic Stevens-Johnson syndrome presented by me, Khairunnadia binti Muhammad. So this is my outline. Start from the introduction until the prognosis. So Stevens-Johnson syndrome and toxic epidermal necrolysis both are the severe mucocutaneous reaction, and it is mostly triggered by the medication. So Stevens-Johnson syndrome, or SJS, is the severe erosion of at least two mucosal surface with the extensive necrosis of lips and mouth and a purulent conjunctivitis. So you can see at the picture below the extensive necrosis of lips and mouth and the purulent conjunctivitis. Meanwhile, for the toxic epidermal necrolysis, it is a severe exfoliative disease associated with a systemic reaction characterized by the rapid onset of widespread erythema and epidermal necrolysis. So you can see at the picture below the widespread erythema and also the epidermal necrolysis. So according to the widely accepted classification, SJS and TEN are considered a disease continuum, means it is the same disease but in the different range, and are distinguished chiefly by the severity based upon the percentage of body surface affected by the blisters and erosion. So you can see at the picture on the right side. So the SJS is the less severe condition in which the skin detachment is less than 10% of the body surface. Meanwhile, for the TEN, it involves a detachment of more than 30% of the body surface area. And we also have the term SJS overlap with the TEN. We describe the patient with the skin detachment between the 10 to the 30% of the body surface area. So for the epidemiology, the estimate incidence of the SJS or TEN is about 2 to 7 cases per million people per year, and the SJS it is more common than TEN with the ratio 3 to 1. And for the onset, it can occur at any age of the group. And for the sex, female is more common than male with the ratio 2 to 1. And it is higher in HIV infected individual and the person with the active cancer. So for the etiology, SJS is most commonly caused by the medication. For example, we have the antibiotic like the sulfonamides, amoxicillin, ampicillin, and ethambutol, isoniazid. And it also can be caused by the anticonvulsant like the phenobarbital, carbamazepine, phenytoin, or the NSAID like phenylbutazone and salicylate. So the drugs that I put right here, which are the sulfonamides, phenobarbital, and carbamazepine, is the most common drug that cause Stevens-Johnson syndrome. And it also can be caused by the infection, like the virus, herpes simplex, enterovirus, adenovirus, measles, and mumps, or can be caused by the bacterial infection like the streptococcus, salmonella typhi, or mycoplasma pneumoniae. So mycoplasma pneumoniae is the most common causative uh, bacterial infection uh, in the Stevens-Johnson syndrome, and it also can be caused by the other, which is the not known causes, idiopathic, uh, which are about over 1/3 of the patient may present with this. So the risk, so there are some person that have the higher risk to get the Stevens-Johnson syndrome, which are the human immunodeficiency virus infection, malignancy, genetic factors, predisposition, and also other factors like for those with the high dose medication, SLE, or for those who are exposed to UV light or radiotherapy. So for the pathogenesis, the pathologic mechanism that induce the skin damage is incompletely understood, but the suggestive mechanism is when the cell-mediated cytotoxic reaction against the keratinocyte that cause the massive apoptosis. So the causes like the drug, infection, and also the risk factor like the immunodeficiency, genetic predisposition, they can stimulate the hypersensitivity type 4, where the hypersensitivity cell mediated cytotoxic reaction they are against the keratinocyte that express the foreign antigen. So at this time, the person or the patient may present with the prodrome symptoms like the fever, malaise, arthralgia 1 to 3 days prior to the eruption of the rash. So from this, it can lead to the cytotoxic T lymphocyte and the NK cell to secrete the granulysin. Granulysin is a cytolytic protein produced, and it also can lead to the drug-specific CD8 cytotoxic T cell to expand and infiltrate into the dermo-epidermal junction, and also can cause the cytotoxic protein and cytokine, like the fast ligand protein that belong to the tumor necrosis factor family, to activate on the keratinocytes membranes and induce the cell apoptosis. So from these three, it can lead to the massive keratinocyte apoptosis, and the patient may present with a prodromal rash, and then can lead to the confluence of lesion, and lastly to the epidermal necrolysis. So the patient may appear with either SJS or SJS overlap with the TEN or the TEN. And this hypersensitivity also can cause the epithelial damage that lead to the sloughing of the mucous membrane. So the presentation may be the irregular erythematous mucus, target lesion, flaccid bullae, mucosa ulceration, cough, and also the conjunctivitis. So for the clinical manifestation, first we have the prodrome period, which is 1 to 3 days before the eruption of rash. So the patient may present with a fever. It is often more than 39 degrees Celsius, influenza-like symptoms, malaise, myalgia, and arthralgia, and also they may present with a photophobia, conjunctival itching, or burning and dysphagia. Then they may develop the cutaneous lesion. So the lesion, they typically begin with the ill-defined coalescing erythematous mucus with a purpurate center. They are often tender to touch, and skin pain can be prominent. The scalp is typically spare, and the palms or soles rarely involved. The lesion, they start from the face and the trunk before spreading to other areas. The atypical target lesion with the darker centers may be present. As the disease progresses, the vesicle and bullae form, and within the days, the skin begins to slough. So the patient may be present with the positive Nikolsky signs, or the may present with the Asbo-Hansen signs or Boulay spread signs, and the ultimate appearance of the skin has been likened to that of extensive thermal injury. So you can look at this picture. This is the target lesion where there is the erythematous with the purpurate center. So this is the Nikolsky sign. So the Nikolsky signs to the ability to expand the area of the superficial sloughing by apply the gentle pressure on the skins. So you can see they can stand the skin on the superficial sloughing area. And this is the Asbo-Hansen sign. So Asbo-Hansen sign is the lateral uh, lateral extension of the bullae with the pressure. So the patient also may present with a mucosal lesion, where the mucosal involvement is about 90% of the cases and can precede or follow the skin eruption. And the painful crust and erosion may occur on any mucosal surface. So for the oral mucosa and the vermilion border are almost invariably involved with a painful hemorrhagic erosion covered with a grayish white membrane. Stomatitis and mucositis lead to impaired oral intake with the consequence of the malnutrition and dehydration. So they also can involve with the ocular, about 80% of the patient. And the most common one is a severe conjunctivitis with a purulent discharge, but bullae may develop. Corneal ulceration is frequent, and anterior uveitis or panophthalmitis may occur. Pain and photophobia are accompanying symptoms. So you can look at this picture. This is the mucosa changes in the SJS or 10. This is the grayish white membrane. And this is the marked conjunctival injection and discharge. So for the urogenital, urethritis, especially about 2/3 of the patient may present and may lead to the urinary retention. Genital erosion are frequent, and others, pharyngeal mucosa is affected in nearly all patients, where and the trachea, bronchial, and esophageal membranes are less frequently involved. The intestinal involvement rarely involved. So for the diagnosis, there is no accepted diagnostic criteria, and histologic findings are neither specific nor diagnostic. So despite of this limitation, the diagnosis can be made from the good history taking and physical examination. So uh, if we can look a suggestive history of drug exposure of a bright illness, a prodrome of acute onset provide illness and malaise, a painful rash that progress rapidly, erythematous mercus, targeted lesion, or diffuse erythema progressing to vesicles and bullae, positive Nikolsky sign, and or the bullae spread sign, oral, ocular, and or genital mucositis with a painful mucosal erosion, necrosis, and sloughing of the epidermal of varying degree. So we might for this history and physical examination, we might suspect the Stephen Johnson syndrome, and we also for the patient that we suspect the SJS or the TEN, tumor epidermal necrolysis, which should um, identify the causative drug, as early withdrawal of the offending agent may improve the prognosis, and the assessment is made based upon the detailed history and clinical judgment. So for the investigation, first we do the complete blood count. We look for the hematological abnormalities like anemia and lymphopenia most commonly, and neutropenia is frequent, and eosinophilia is uncommon. And we also look for the liver function test where they have the mild elevation of the transaminase and also the hypoalbuminemia. For the renal function test, we look for any electrolyte imbalance or increased blood urea nitrogen and glucose. This is due to the complication of the loss of the fluid, and also the inflammation blood test elevate CRP, ESR, bacteria or fungal cultures we take from the blood wound or lesion due to the patient have the higher risk of superinfection and sepsis. And lastly, we do the chest radiograph in all patients due to higher risk of pneumonia and interstitial pneumonitis. So the skin biopsy, last one, is a routine histopathology examination, and possibly direct immunofluorescence is useful in confirming the diagnosis and excluding other conditions that may mimic SJS or 10. So At the early stage, we may look the appearance of apoptotic keratinocytes that are scattered in the basal layer of the epidermis. And there is a perivascular mononuclear inflammatory infiltrate in the papillary epidermis composed primarily of T lymphocyte. And this infiltrate is not a diagnostic yet. As the lesion progresses, the frank subepidermal bullae develop with a full thickness epidermal necrolysis. So the hallmark of the SJS of 10 is the keratinocyte necrosis that ranging from the partial to the full thickness epidermal necrosis. And the direct immunofluorescence is always negative. So you can see in the picture below, at the A picture, diffuse coalescing erythematomucus and patch with a dusky center and multiple bullae in a patient recently started on several new medication. So this is how the appearance. And for this histological diagram, uh, picture, there is a cell poor subepidermal blister and epidermal necrosis. The dermal inflammatory infiltrate is sparse. So there are many differential diagnoses, but I mentioned a few. So first one is the erythema multiforme. So the erythema multiforme, they can present with a typical target lesion or targetoid lesion, but they are predominantly located on the extremities. And the bullae and the epidermal detachment is involved less than 10% of the body surface area, and the most important part, it is associated with the herpes simplex virus about the 90% of the cases. For the erythroderma and the erythematous drug eruption, they can mimic early SJS of 10, but they lack mucosal involvement and the prominent skin pain of 10. So for the acute generalized exanthematous pustulosis, they are difficult to differentiate from the SJS or 10, but they develop within a few days of exposure to the offending drug. Most often is the beta-lactam antibiotic, and they can resolve without the treatment in 1 to 2 weeks after the drug discontinuation. And lastly is the generalized bullous drug eruption. So this is the extremely rare form of fixed drug eruption, but the mucosal involvement is usually absent compared to the SJS. So for the complication, in the severe cases, the skin detachment can lead to the acute complication like the massive loss of fluids, electrolyte imbalance, hypovolemic shock, multiple organ failure, bacteremia, abdominal compartment syndrome. And the person with the SJF has the higher risk for the bacterial infection, especially sepsis or septic shock commonly caused by the Staphylococcus aureus and Pseudomonas aeruginosa are the main cause of the death in the patient. They also may have the pulmonary complication like pneumonia, interstitial pneumonitis, cough, increase in respiratory rate, and this may progress to acute respiratory distress syndrome. And lastly, for the GI complication, it is result from the epithelial necrosis of the esophagus, small bowel or colon, and they may present with the diarrhea, melena, small bowel ulceration, colonic perforation, and small bowel intersusception. So for the management, first is the supportive care. We should admit the patient to the isolation room where there is possible. And for the shock patient, we give the IV fluid resuscitation. We should apply the good nursing care like the barrier nursing and hand washing. And we may give the patient to use the air fluidized bed to avoid the bed sores. And we give the patient the adequate nutrition. So for the specific treatment, we eliminate the suspected offending drugs, and we may give the IV immunoglobulins as it arrests the progression of the disease and helps to complete the reepithelialization of the lesion. Then we monitor. We maintain the body temperature. We carefully monitor the fluid and electrolytes. We look at the blood pressure and the pulse rate. And also we monitor the intake or output chart, daily waking, and renal profile. So for the prognosis, the overall mortality rate, it is about 25%, ranging from the 10% for the SJS to the more than 30% of for 10. And the most common cause of death is due to sepsis, acute respiratory distress syndrome, and multiple organ failure. So the recurrence of SJS or Earthen, they may occur if the patient is re-exposed to the offending drug, and Scorton is based upon the 7 independent and easily measured clinical and laboratory variables, and it is being assessed rapidly on the patient admission to the hospital. So for the score, the higher the score, the poorer the prognosis. So I think that's all from me. This is my references. Thank you.
Thank you. It is an important point which must be noticed also in any skin lesion. Besides the characteristic of the skin lesion is the mucous membrane. You must get a look to the mouth, to the eyes, which is this part of mucous membrane which can be affected with this severe disease, because it can be life-threatening if not diagnosed early and intervene. Okay. Do you have any question? So I think you are for presenter. You can just make one more simple presentation, the skin manifestation of systemic disease. Everyone can put like 3 only slides, like SLE we will find in the skin, but we are searching for another, like rheumatoid arthritis, okay, like rheumatic fever, like there is a lot of disease. That just right skin manifestation of systemic disease. So when I said, no, it is not pure skin. It is a part of systemic disease, like dermatomyositis. You will find some lesion in the eye and in the knuckles, and you must go directly to the myocytes, okay? So it will give you an important view that skin can be only skin problem, but in many situations it can be a part of other disease like neurofibromatosis. I will find the cafe only spots, but I must go behind that to look for the other side. Can you do that? I think it will give benefit to the whole patch, inshallah. It's okay. Don't go deep, just few examples from every one of you, 3 slides like that. It will be very, very good, beneficial for them. Okay. Thanks for your presentation today. And I will send your, inshallah, marking to your colleague. Assalamu alaikum wa rahmatullah.
Waalaikumsalam. Thank you, doctor.
Thank you.
You are welcome. You are welcome.